Okay, well, it's 1:32, so I think we can get started. It is going to be pretty lightly attended today. Jeff and Marissa are both out. So I think we can start to roll through some introductions. This is the Data and Systems Integration Committee meeting. I'm Adam Kuhn. I am the HMIS data analyst for the Office of Homelessness Prevention and Intervention. And you can go ahead.
Hi, my name is Lyndon Bond. I'm an assistant professor at the University of Kentucky College of Social Work.
I'm Amber Cronin, and I'm here at the Hope Center, the Director of Homeless Services or Emergency Services.
Cameron.
Sorry, I was trying to log on to Wi-Fi. My name's Cameron. I'm here for Greenhouse 17. Diane couldn't make it today, so.
Evan, we're doing intros. You want to go ahead and grab yours?
I'm Evan Charles, in for Marty Jones at Comanche Council.
Go ahead.
Ronald Delgado, job counselor at Jubilee Jobs of Lexington, and a newest OHPI board member.
Awesome.
Liz Sheehan, I'm on the city council and a HPI board member.
Alicia Buras at Volunteers of America Mid-States.
Christina Ellison at New Beginnings Bluegrass.
Cool.
I just verified the double stars mean it's a COC vote.
Okay, that's what
And
I was hoping.
it dropped off our agenda at some point, but I have another agenda that has that on there.
Appreciate that. Yeah, I saw the stars and didn't know. Okay, awesome. I will remind everybody before we move on, there is a sign-in sheet over here. If you'll just hit that as you're leaving, if you did not hit it already, it just helps us keep track of who's here after the fact. And then we will move on to our second agenda item, which is the approval of the minutes from the last meeting. I'm hopefully not going to stumble through this too much. It's a full membership vote. We do need a motion to approve those minutes. I can give folks a minute to look over them if we haven't done that already, but otherwise I would take a motion.
Move to approve.
Appreciate that. And then we would need a second.
Seconded.
Okay, awesome. And if there's no discussion, we can take a vote for all of those in favor. That would be anybody or everybody. Any opposed? Okay, awesome. I think that one will pass then. We write down. Okay, great. And then we're going to move straight into a presentation from our friend from UK who will be presenting on the 2025 hospital point in time count. Lyndon, if you want, we can drag this cord over to you. It's pretty long, so you can probably stay right here. And we're both shorthanded today, so we'll have to do the tech setup live. It's a full HDMI, and if you can't get it. It's powering on.
Let's see if this works.
I just fired it up. Do you think it's moving? Yeah.
All right,
Yeah, cool.
great. Well, thank you so much for having me today. As Adam mentioned, my name is Lyndon. I am an assistant professor at the University of Kentucky College of Social Work. And I'm here today to share a brief overview of some of our findings from a hospital point in time count that my colleague Abby Latimer and I did in January. To learn a little bit more about rates of housing insecurity and homelessness that we're seeing across the UK hospital systems and sort of how those add to or complement maybe some of the 2025 Lex count findings. And so just a little bit about me before we start. I'm a researcher at UK, and a lot of my work really revolves around understanding and improving our homelessness response systems and addressing the intersection of behavioral health and housing insecurity and homelessness. I have a long history of direct practice work. I was an outreach worker for a long time, worked in permanent supportive housing, which sort of led me to research and policy work. So happy to be here today, and always happy to chat or answer any questions you have about the work we do or this project in particular. So I'll just start with a brief disclaimer. This work was funded by the University of Kentucky, CCTS, Small Grants Program, the College of Social Work, and the College of Medicine. And we always want to thank our champions over at UK Healthcare, including Lindsay Vaxdale. Okay, so just a little bit of background on the hospital point in time count. As we know, the point in time counts that are done annually in each community don't include people who are institutionalized, including staying in hospitals. And so building on some work that was done out of Denver, trying to understand who was experiencing homelessness on the day of the count there, we decided to conduct a hospital point in time count this year to better understand the rate of housing insecurity and homelessness among folks who are hospitalized on January 29th this year. And so we expanded beyond sort of the typical scope of a point in time count to also ask about different experiences of housing insecurity to really understand sort of like risk factors for entering homelessness, as well as some questions about access to behavioral health care and overall health as well. And so a little bit about our methods. Again, this was conducted right around the same time as the general point in time count on January 29th. We used 60 volunteers who were staff at the hospital, social work students and other students, and other faculty at UK to sort of share the survey widely and conduct the survey with folks who were hospitalized at UK during that time. And we covered Chandler, Good Samaritan, and Children's Hospital. So really trying to see, again, across the whole UK, Lexington hospital system, what was the housing status of folks admitted that night. So here is just a brief overview of sort of how far we got. There's a lot of beds across those three hospitals, and there were 684 possible rooms. We ended up with 310 people who agreed to participate in the survey. So that included adult patients and then caregivers or parents of children who were in emergency, who were admitted to the hospital or in the emergency department. I'm not going to go into this a ton, but this just shows we sort of were able to survey folks from every unit in the hospital, really representing sort of the reach of this initiative. Now I will jump into some brief demographics of who agreed to participate. So here is a demographic breakdown of who consented to participate in the point in time count survey. And really what you can see is that we had sort of an even mix of female participants and male participants, and the vast majority of folks who chose to participate were white. And then we also asked people what county they were staying in prior to coming to the hospital, as well as some questions about where they plan to return to after they leave. And as you can see, the majority of patients were coming from sort of Fayette and surrounding counties, but we had sort of a wide range of patients.
Are the darker blues mean that
Darker blue means more people, yes. All right, and here is just really the main finding of this project, which is what is the housing status of folks who participated in the survey. The vast majority of people were staying somewhere that they were owning or renting. However, we had 42 people who said they were staying with friends or family, and 10 people experiencing homelessness. So given who I'm speaking to today, the first part of this is really focusing on sort of what we learned about people experiencing homelessness accessing healthcare that night. So of those 10 people, 2 people were experiencing unsheltered homelessness prior to coming to the hospital, 4 in transitional housing, 2 in emergency shelter, and then 2 in a hotel or a motel. Most identified as male, aligned with our overall demographics, most were white, and folks ranged in age from 38 to 61. And so here on the right, I just wanted to show one of the things I think we hear a lot is people come to a city, even though, right, they're maybe not from here. And we really sort of highlighted, like, we're asking people, where were you before you came, and can you return there after you leave? And so even among the 10 people experiencing homelessness, the majority are saying, I came from Fayette and I plan to return there. So that they're not sort of like not adding to this conversation that people are coming from different communities and then sort of staying here. We also mirrored a lot of the questions on the Lexington survey around how long have you been experiencing homelessness? Is this the first time you've not had a place to stay? And some of those questions around chronic or long-term homelessness. So 3 people shared that this is the first time that they have experienced homelessness, with 2 out of 3 of those people saying that they're over the age of 50. So again, sort of aligning with what we're seeing a lot with older adults experiencing first-time homelessness. 6 folks identified that they have experienced repeat or chronic or long-term patterns of homelessness. Half of the folks experiencing homelessness who participated in this survey said they were a survivor of domestic violence, and none said they were veterans. And then here on the right, we also asked everyone, can you share sort of what are the reasons for you not currently having a place to stay? And it was sort of like a select all that apply question. So we had a wide range of answers, including dissolution of family systems, whether that's from a death in the family or family and personal reasons, not being able to afford housing, some of those behavioral health or health issues. And then one person also noted that they had lost their housing due to a natural disaster. We also, given that this was done in a hospital, wanted to ask people about their health. So again, this is just sort of a summary of those 10 people who identified as experiencing homelessness. Most people reported their overall health as poor. Again, I think there's a lot of reasons for that. One is that they were admitted to the hospital, so there's probably, a health issue going on. But 6 people also reported having a primary care provider that they've seen. We saw high rates of chronic health conditions, including high blood pressure, diabetes, heart disease, or congestive heart failure. And then we also asked questions about behavioral health. So 1, on the mental health side, has someone ever told you or have you ever been diagnosed with a mental health condition? And 5 people said that they did. And then on the substance use side, same question around substance use, and 2 people reported having a substance use disorder. We also asked a question around, did you receive any treatment for this condition in the past 12 months, or did you want to? One of the things I'm particularly interested in is sort of this gap of, like, how do we better facilitate connection to services for people who want them? And so 2 people, when it came to mental health, said, I did not receive mental health treatment, but I was interested in receiving it. We actually had no one report any unmet substance use treatment needs. I'm going to pause there. That is my brief overview of sort of 10 people who were experiencing homelessness in the UK health system on the 9-point in time count, sort of adding to maybe that 925 number that we got this year from the Lex count. See if there's any questions, and then if folks are interested, I also have like another section on housing insecurity more broadly and sort of what we're seeing in that space.
Were those 10 people in the emergency room or admitted, or is it different?
I can grab that number for you. We interviewed people both who were in the emergency department seeking care, as well as people who were admitted.
Okay. I just feel like most of the homeless people that show up are probably not admitted, but that's a lot for an emergency room. So.
Yeah, we can. I can definitely follow up with you and pull that. And we did, again, sort of interview across Good Sam, Chandler as well, so pull sort of like where folks are staying and what unit, which I think will give us a little bit more detail on that.
So does this include the Empath Center as well?
It does not. No.
Sorry if you said that and I missed it at the beginning.
We sort of focused on Good Sam and Chandler, and then we're going to expand to sort of, the goal is in the future to expand to some more units and departments and hospitals that we know are sort of seeing more maybe displaced folks or unhoused folks. in the future. Is there interest in like the housing insecurity piece of it, or are people like, we can have a short meeting?
I'm interested.
Okay.
Well, before you go on,
Yeah.
I have one really small one, just because we made a new housing triage assessment, and I know Marissa spent a lot of time thinking about these like self-identification questions for things like substance use and mental health. I noticed you guys use the language, have been told they have a mental health condition. Can you talk a little bit about like why that language? Is that to identify a diagnosis, like without the word diagnosis, or what's the motivation for that language?
Yeah, and I can pull the exact language we used. I think that the language was, have you ever been told you have or been diagnosed with? And I think the have you been told just opens it up a little bit more to either self-identification, or maybe you don't meet like a clinical diagnostic criteria, but someone sort of like has engaged you in that conversation around substance use. We pulled it from somewhere, so I can find the official source for that as well.
That'd be awesome.
Write that down. All right, so now I will jump into sort of the second piece of our study, which was really around housing insecurity more broadly. So housing insecurity can encompass a wide range of housing situations, as we know: unaffordability, instability, overcrowding, unaffordability, if I haven't said that yet, and then homelessness. And so our second sort of aim of this research study was to really understand what other forms of housing insecurity are people facing in the hospital. And so ultimately, we have categorized sort of what we found into three large categories of housing insecurity: no housing insecurity, less severe forms of housing insecurity, and more severe forms of housing insecurity. So we conceptualize these three different categories really as a way to think about who are the people maybe most at risk of entering homelessness in the near future. So we asked people about, can you return to the place you were staying after you leave the hospital? Have you been asked to leave the place you're staying? Are you staying somewhere only temporarily? And do you have severe or moderate housing quality issues? And if someone responded sort of like positively to any of those situations, we categorize them as more severe. If people were able to return to their housing and had not been asked to leave, but had like unaffordable housing or had concerns about losing their housing, there's a typo in here. The less severe does not include all of that. Less severe is you have unaffordable housing, you have concerns about losing your housing, but you haven't been asked to leave yet. As like starting to think about some forms of housing insecurity and maybe sort of getting on the radar of other services or supports you might need to prevent homelessness. And then people who were able to return to their housing or had affordable housing and no housing quality programs, we sort of conceptualize as experiencing no housing insecurity. So that is sort of where we've ended up, and I will talk a little bit about how we got there. So one of the things we were interested in was housing instability. So who has been asked to leave their housing, who's received eviction notices or foreclosure notices, and who's staying in temporary housing. And so the blue here is the adult patients, and then the orange is the adult caregivers. And so we had 13 respondents who said that they had been asked to leave their housing, or 14 respondents who had said they'd been asked to leave their housing, and 3 who had received an eviction or foreclosure notice. And then we had 25 people who said they were staying in temporary housing, so not a permanent housing situation before they were coming to the hospital. And then we also asked people a little bit more about some of these housing insecurity indicators. So we had 21 people who said they were unable to return to where they were staying where they were staying before they entered the hospital. So sort of this idea of, when I leave the hospital, I'm not sure where I'm going to go. We also had 36 people who were worried about losing their housing. And over 100 people said they're paying more than 30% of their income towards their housing costs. We use 30%, which is sort of like the general indicator of housing unaffordability, but I think some other measures for this could be, are you paying more than 50%, sort of recognizing the like extreme housing unaffordability. And then we also had 78 people who said that in the past 12 months, there was a time that they were unable to meet their essential housing expenses or other expenses. And then just wanted to point out, of these people who were unable to return, 11 people were in a situation that they were owning or renting. So people who maybe in other measures would be conceptualized as housing stable, they own a place or they rent a place, they're actually saying I can't return to where I was staying. And then we also asked about housing quality. We know housing quality is tied to a lot of health outcomes, and also if you have very poor quality housing, it's also likely unsafe for you and may lead to displacement. So we asked people about a number of different housing problems. You have things like water leaks, damage from a natural disaster, holes in the wall, rodents, working electricity, running water, working toilets, and most people said they had none of these problems, which is really positive. We had 47 people say that they had at least one of these problems, and we had 20 people who said they have 2 or more of sort of these big structural or housing quality issues. So things that we just wanted to highlight when we're thinking about housing situations of folks in the hospital. We had 4 people say they either had no running water or a working toilet. 3 people who said they were living in a house without electricity. And one of the ones that I think is really telling is 15 people who said they had unrepaired disaster damage or other structural damage. So people living in homes that had been damaged by flooding or some other form of natural disaster that maybe was making their home less safe to live in. So HUD has a way to measure the severity of housing quality or housing maintenance issues. We adapted that a little bit to identify who was experiencing severe, moderate, or no housing quality issues. And 26 people, which is a little less than 10%, were experiencing severe housing quality issues. They likely would be returning to after leaving the hospital. And then last, again, because this was done in a hospital, and because Abby and I are both health researchers, we also asked a little bit about health of the adult patients who we surveyed. So we asked the question, again, around substance use. Have they ever been told, or do they think they have a substance use disorder? Most people said no. We had 37 people say yes, and again, that included 2 people experiencing homelessness. And of the people who identified as having a substance use disorder, around half of them had received substance use treatment in the last 12 months, and around 10% didn't, but wanted to. And similarly with mental health, the majority of people said they do not identify with having a mental health disorder. 66 people did say they did, which is around 20%. And when we're thinking about treatment access for that, again, around 50% of people who identified with having a mental health disorder had received treatment, and a little less than 10%, so 5 folks said they hadn't received treatment, but they were interested in it. And last, overall health. Again, I think some of this is a little skewed because we were asking people who were in the hospital how they identified sort of their housing status. Most people sort of said my health is fair, poor, or good. We don't have a lot of very goods or excellence, as you can see there. And then we also asked people about their symptoms. So what kind of health symptoms are you having? I'm basing this on like a palliative outcome scale. When it came to things like how often are you having shortness of breath, are you feeling anxious or worried, or are you feeling pain? And then last, just highlighting, the rate and the frequency of some of these chronic health conditions that we're seeing in folks who are hospitalized. So over half reported having high blood pressure, and over a third diabetes and high blood sugar. But again, sort of aligning fairly well with what we found in just the folks experiencing homelessness. Most people, nearly 90%, did have regular contact with a primary care provider, which is often sort of an indicator of linkage to care, which was, I think, a nice finding to see. So I will go ahead and end it there. I know that was like a lot of things I just threw at you. Happy to answer any questions or find a time to chat just about our ongoing work or questions you all have.
What were the demographics for this second group?
Yep. I will pull that up. This is the demographics of our overall sample. Primarily white, around 50-50 male, female, and the average age was right around like mid-50s, ranging from 18 to 95.
Did you add, like I'm interested particularly in the home issues like the repair or like disrepair kind of issues? Were these, do you have any way to identify if they are all renters or if any of them are homeowners?
Yep, we do have a way, and we can pull that just to sort of look at, it sounds like, who's owning their home and has housing quality issues versus sort of those like things that are not repaired from renters. And I know that there's ongoing conversations sort of around renters' rights in Lexington right now, and we have a whole separate presentation just on the renters, which highlights some of that as well. But I can get that.
I'd be interested in that.
Yep.
But we have some like housing repair assistance programs, and so I'm also interested in like how many people might be having repair issues with their home or problems with their home, but then are also a homeowner. Because the funds that we have that people can qualify, you have to be the homeowner.
Mm-hmm.
And so if there's a way for us to get that information to people, I kind of want to know.
And I think some of the things we've been thinking about in regards to what we found is this connection between housing insecurity and exacerbating health conditions or returning to the hospitals. And if there is a way to effectively like develop some sort of better screening system or referral system for maybe programs like the one you were just referring to about, can we connect people with repair programs for their home, and would that maybe help them increase their stability and not have to return to the hospital? Or if they don't have electricity and they need to keep medication cold, is there a grant or a program that we can sort of like help them get their electricity back on, pay any electric arrears, so they can, you know, not return to the hospital, and sort of thinking about the connection there.
Well, even our emergency management department would want to know some of that, like medication kind of situations, because when we have widespread outages, it helps them triage faster on where power needs to get restored or what kind of like supplemental things they need to give homes. And there's ways like people can call like 311 in that moment, but if we had a way to like kind of have some catalogs of that for people who chronically have that, that would also be helpful.
I'll go ahead and end it there. Abby and I are both always happy to talk through this, and I think one of the things that I always like to say is I want to be like a resource to community members if there's ever a research question you all have or a question that you want answered, but you don't have the time or capacity to do it. We would love to partner with you and sort of think through how we can be supportive of the work you all are doing. So thank you.
I'll just say publicly thank you as well. Lyndon has been working on the program, the data collection that we've been doing for the Villages program, which is around kind of how you can help people who are seniors or have a disability, like have a more independent living space, because you like work kind of in a network to provide supportive services. And so they've been helping us with that data collection.
I will say, too, thinking about that housing insecurity section, our office internally sometimes talks about how little of our work has to do with like preventative efforts. And we've just started to review some of the Flex Fund stuff that's coming in because we paused that, and looking at it this morning, about 70% of the services, like the paid services that were provided, were prevention services. So I think there's some overlap with like that being accessible in some cases to those households. But I do think it's really significant because so much of the outreach that we provided was obviously to our COC and homeless service providers, and you know, another that housing insecure group is kind of the primary user there. So that's been interesting to review, and hopefully something that we get to continue to talk about in some of these committee meetings as a group that maybe we're not reaching with a lot of our services at current. All right. Well, we will jump to the next agenda item, which is new business and our fiscal year 26 HMIS data standards update. I am going to pull some notes on this. It has been a little bit of a saga. We just heard from HUD for the first time in my memory on this yesterday at about noon, and it was an email with 5 bullet points. Now the government is shut down, so I do want to take as many questions as I can, and I'll submit those to HUD. We may not get an answer super quickly, obviously, but I definitely want to have a catalog of those for them to return to. I'm going to go through the list of the updates that HUD gave me, and then I'm going to review some of the notes that we've gotten from our vendor previously. We've talked about some of these in this committee before and at our board meetings. And for our service providers, the changes that our vendor has reported to us are in effect. And those have been confirmed previously and have been instituted starting today. So this stuff is relevant, even if there isn't a ton of guidance from HUD on it yet. And I think the updates from HUD that I'm about to give are a little disorienting, but stick with me for a second. So the first thing is that the HMIS data standards for FY26 are in the process of being approved, but they actually have not been finalized as of yet. Despite that, vendors have been instructed to push the changes out starting on October 1st. So typically this is when our fiscal year standards would go into effect. Even though they haven't been approved by HUD, essentially the system that we're working on ought to be the system that we would expect to be working on the same timeline as usual with this October 1st start date. Because our systems have shifted and vendors have implemented that change, Marissa sent an email about this, I think last Wednesday, but Sage is now going to accept APRs and capers only in the FY26 format beginning today. So that might look a little bit different. We'll talk about what those reports look like now with the changes in a little bit. The one thing that HUD has given us that's new is that because we don't actually have access to any kind of approved documentation and standards as of yet, they are apparently granting a 90-day grace period for data quality. The guidance that they've given is that end users should be trained on the FY26 changes as soon as possible, but data quality in this 90-day window won't be evaluated. Obviously, I've never seen anything like a grace period from HUD, so I don't really know what we ought to expect. And I'll mention this a couple of times as we go through all of this, but I'll just say that I think locally, we are going to operate as though we weren't in a kind of grace period window. That just gives us a margin of error, obviously. But when we talk about the changes that we're going to see on the system, we would like for our end users to be addressing those changes immediately, starting today. Particularly because we've had the opportunity to talk about some of them before, and obviously because there's a grace period, you just won't be penalized if we're struggling at all to catch up. So that's a good thing for us. But we will move on to the changes that we're aware of. The weirdness of this has been that vendors haven't been allowed to provide documentation to us about the standards. Specifically, like HUD has told them they aren't allowed to share the data dictionary or anything they've had access to. So what we have gotten from them are release notes for when they change HMIS, basically. Like an update is coming, this is what's going to be on the update. So that's been able to kind of tell us what changes we ought to expect in terms of data entry. They met with us on Friday in a webinar to kind of finalize those patch notes and let us know what we were going to be looking at. So I'll run through those pretty briefly. Again, most of this is stuff we've talked about, or if we haven't, it's relatively minor elements that may not even affect some of us in the room. The big one is that in addition to gender, end users will begin to collect on the sex data element. A reminder that we will be collecting both of those locally. So gender has technically been retired per HUD in terms of data collection, but as part of our local data quality, we'll continue to collect gender. We will just also be adding sex. Also to remind you, these are completely different fields. We can't translate one data point to the other. We'll need to collect that data manually from our clients. One thing that is different is when we had first introduced this new data element, we thought it might appear like on assessments when you all get into like your entry exit and stuff. This is a good thing. Sex is going to appear on the client profile. So probably like we would expect with date of birth, gender, etc. So that will technically be created at the point of record creation or on that client profile tab. Know that this change and all of the changes that I'm about to mention are, they matter for data collection for clients enrolling on or after October 1st. So if you're a permanent housing provider and you've had somebody enrolled for like 3 years, you don't need to worry about going and getting this data element for them. They'll be grandfathered in. Same with somebody who you may have spoken to like a week ago even. So technically, it is just for anybody that would be enrolling today or in the future. In terms of that October 1st start date, again, we do have that grace period, but we will operate locally as though we don't. We would like to institute these changes as quickly as anybody is comfortable. If after this meeting you have questions or as we send out documentation, please reach out to me so we can make your staff comfortable with these changes. And then we'll kind of continue on through the actual stuff that's going to change that, again, maybe a little bit newer to us, but should be pretty small and already part of our workflow. Sexual orientation and translation assistance required fields will technically be retired. It doesn't look like HUD is even going to include language about retirement. So like everything for your users will look the same. We're going to continue to collect those data points here because our vendor hasn't been required to change the language on the system. Realistically, it shouldn't change. So you might hear about something like HUD not collecting information on sexual orientation. Because we're continuing to collect it locally, nothing changes for our system. So that stuff's easy. Family critical issues is a question or a series of questions that appears for our RI providers, runaway homeless youth. In those sets of questions, previously clients couldn't answer that they didn't know a particular answer. They've now given us the opportunity to indicate that somebody doesn't know or that a particular answer wasn't collected. So those response fields have changed, but that's a good thing. They're broadening it a little bit, so we appreciate that. And then our SSVF providers actually do have new pick list values and a new data element, actually. So at least I'm glad you're here because that's really timely. For service type, we can now collect healthcare navigation. That's something that will start today. So if a service like that has ever been provided in the past, you wouldn't backdate it. It would just be for interactions starting today or going forward. And then they now have a data element for mental health consultation if somebody has, I think, pursued that or been advised to pursue it. And then a financial assistance start date, which comes in addition to already some like dating information for financial assistance. So that one's maybe a little bit cumbersome, but we'll talk offline about that, obviously. And that's really it. So we have our new data element sex. We've got retirement of some fields that won't matter to us locally, and then a couple small changes on fields and responses. But fortunately, even though we weren't given anything in concrete, a lot of these changes are stuff that we've been able to anticipate. I'll just note before I go to the next item on this, our vendor said to us like countless times in the webinar, obviously something could still change because it hasn't been approved yet. I wouldn't expect that, but it is just something to note that like we might be sending out correspondence later this month. I think the tentative timeline would be something like 2 to 3 weeks for us to see an approval. And we may be following up with something that is slightly different than what we're reporting. So just please like continue to be aware of any correspondence that we send out about HMIS data standards because it could end up being very important for our federal reporting. Before we jump into like what this means for reporting and stuff, does anybody have questions about changes to data elements or like our HMIS system? Mostly stuff we've talked about, so I don't expect that anybody's really shocked. Couple notes on reporting. Obviously with gender being retired, despite the fact that it will still appear on HMIS, the APR and CAPR are federal reports. So because HUD is using those reports, they have removed gender. We can still report on gender locally, and we will. So we'll still be making that like a point of emphasis for data collection. And if you guys have gaps in that data, I'll report those out to you. You won't be able to tell. But if you have questions about your own reporting on gender, you can reach out to me and I can make you a custom report just so you can keep track of it if you want to. You know, given that one's created at point of record creation, I'm not super worried about any of our providers keeping up with it. But if you had an interest or wanted to know about any kind of demographic splits or anything with gender, I'm always happy to get you that data. I will note that, and sex now will appear in the APR because it's been added to the profiles. The weird thing about the sex data element is it's technically not a UDE, a universal data element. That doesn't necessarily matter for you guys, except that rather than appearing at the top of your report, like with date of birth and stuff, it's gonna be in section 24, which is like as far down the report as it sounds. So kind of unwieldy, but something that we will want you guys to be aware of. That should be in your report starting today. I actually had to email KHC to make sure that we implemented that change, and I think there was a slight delay, but as of the end of this meeting, you should be able to like pull an APR and find that. So I would encourage you to investigate it. If you feel like you can't see it or you don't know where to find it, feel free to let me know, but it will technically be section 24E, so it is way down your APR. So the other thing, and I'm going to throw my computer onto the screen in just a second to talk about something else. I can show you on the APR what this is going to look like, but the other confusing thing about sex is we obviously have a lot of clients who are going to be grandfathered in that don't require us to collect this data element because they were enrolled prior to October 1st. Those people are going to still show up in your report as data not collected. So you'll have like a massive count of errors potentially if you serve like a big client base. Personally, my advice would be, and I think we talked about this a little bit at DSI last time, if you have a small caseload, like 10 to 20 clients, so a lot of our PH providers, I would encourage you to just update that data element for people who are like retroactive anyway, just as you like do an annual assessment or something. So if it's not that much of a labor burden, just update that for your caseload, even though we're not required to, just so we can get in the habit of cleaning up those APRs like we normally would. If you're a provider that has like hundreds of clients, like a street outreach or a shelter, let's plan to talk about how to clean up your enrollments so that we can get an active number and you can start to chip away at those stayers who are showing with an error in the sex data element. So if you're not actively keeping up with somebody, let's say in a street outreach project, I would like to know that so that we can start to close them out. I can help you with a report to show you maybe who you're not talking to currently. But we would want to clean up that data so that whoever is showing as not having collected this element, we have some opportunity potentially in the future as you continue to work with them to get it updated. So our goal would be just sort of passively to optimize this as best as possible. But like I've been saying, we have a grace period, and for anybody that was enrolled before, you're not going to be penalized. So it's okay. It's just a matter of like good practice. If you're talking with somebody, update this field, I think is what our MO would be. And if you feel like you have such a burden of clients, then reach out to me for something like an outreach project so that we can update your stayers. Questions about reporting or any of that kind of local guidance? Okay. And then the last thing, and I am going to throw my computer up for this. I'll start to talk through it, but we were made aware of a potential bug that was going to happen with this update, and it ended up not being the case. They ended up patching it, so I didn't have to send out any correspondence or anything. But I want to kind of pick your all's brains really quickly while we've got some providers in the room, because we could still institute this change, and you all may actually find that it's helpful. I'm going to pull it up and show you. So I want us to think about our search screen and how it looks now compared to this. This is on page 6 of your packet too, for anybody who's checking that. We made a little one-pager about this and then didn't end up using it. But at current, our client search screen, I believe, cuts off right at about the US military veteran question. So you can search on these elements, and that's it. We were told that we were gonna have to include demographics in our search screen, so we started to play around with this change, but again, we didn't have to push that through today. The thing about demographics on this search screen is like, obviously all the data that you input, when you create a client, this gets pulled onto their profile. So I'm kind of the opinion that if we had this, it would be, user creation would become a little more convenient for us. And I would remind folks, like, when you think about creating a household and like those additional household members, you start here and then you have to go to the profile and add all their demographics every time. The other thing that's going to be intuitive, this is a sandbox, so this isn't really our website, but on our website, ideally it will actually show sex and gender, so that additional data element will just be like really intuitive for us to add in, because it'll just all be right here at the point of client record creation. Looking at this, do we see any issues? Is this something that we would be like enthusiastic about? Do we care at all? Does anybody have any kind of feedback about a new search screen?
I'm enthusiastic. I like it.
Okay, love that. Anybody concerned at all?
Is there a downside?
I mean, I don't think so. We like to float stuff like this at DSI. I have not been made aware of any kind of downside from a data entry standpoint. I mean, to me, it looks easier. The vendor is the person that presented us with this, and yeah. I mean, the fact that you're asking me if there's a downside, hopefully that means it seems solid. Okay. If you have thoughts otherwise, you can definitely get back to me, but I think this is gonna make data entry just a little bit smoother, and for that reason, I'm kind of inclined to push it. I won't do that without sending out a bunch of system correspondence so that everybody's aware this change is coming, giving a little bit of heads up, just so that when you pop onto your search screen, you know, you can make sense of this, or your end users will. The one kind of bit of weirdness about this that again, I think could be helpful for us, and maybe this is our downside. This change is going to be instituted at the provider level. So when you guys do EDA, you are like entering into a provider of some kind. What I would be doing is updating every provider to have this screen. So one, if for some reason it didn't work for your particular project, and actually it's at the project level. If there was some project where this is a problem, we could optimize it. You wouldn't have to use this screen. But what that means for EDA is your users would be able to tell if they were in the right, not in the right EDA, but using an EDA at all, if this screen popped up. Because if you're just like a regular user who's not entered into EDA, you're gonna see the shortened version of our search screen, that original default, I believe. So I don't think we have any providers who really struggle with like using EDA in the room, but there are some that do, and this would just serve as a reminder where if you pop onto this search screen and you're not seeing all of our fields, it probably just means you forgot to click into an EDA mode. So again, like that to me feels a little helpful. It's a checkpoint for us, which I like. So if there is no thought on that, it's a conversation that we're having internally, but my opinion on it is that I think it would be helpful, and it sounds like we're at least partially enthusiastic, so that's cool. And that would be it for new stuff starting today, and for our new business agenda item if nobody has any other thoughts. So that's great. For continuing business, thinking about the housing triage updates, I'm not gonna do a coordinated entry report. Marissa's gonna handle that at our next DSI committee meeting. I did wanna follow up on our housing triage training and just kind of like thinking system in general. We have started to roll that training out a little bit. If you haven't gotten in touch with our office yet about housing triage tool for your agency, please do. When we developed that training, we kind of developed it for different levels of system literacy. So I think Marissa did the webinar that was like really, really long and exhaustive. Those presentations are an intro to the COC, an intro to coordinated entry, and an intro to the assessment. If you're, for example, a provider that's already providing the assessment, you're not going to have to do 3 hours worth of intro to COC training and stuff. This is something that's going to depend on your agency's system literacy and the degree to which you're already implementing something like housing triage or coordinated entry. But we do want to remind people to get in touch with us. The thing that I wanted to float, or at least let you guys know about for that training, is after having executed at least one that I participated in, I don't know how many others Marissa's given, we are realizing that when we talk about coordinated entry, we mention diversion a lot. We don't necessarily spend a lot of time training on it, and we're feeling like this would be a much more engaging training if it included a diversion component, and it might actually be quite a bit more helpful for providers too. It feels like, for example, when I talk about coordinated entry at new user, people are really enthusiastic about this resource and this tool, and then they realize that it's for like a very particular client case, and a lot of that enthusiasm kind of fades away. We're feeling like if we can equip people a little bit better for those diversion conversations, maybe we come out of this training a little more motivated to be doing like some general housing problem solving. It's going to make the training just a little bit longer, obviously, but I think of all the elements, even for some of our most experienced like triage providers, that course or that additional component should be hopefully pretty exciting. So that is something that Marissa's working on currently, but wanted to give folks a little nugget, I guess, to maybe get excited about in terms of that training, because I don't think we've had all of our providers reach out yet. So please do, if you haven't already, or let me know after this committee meeting's over. I'm happy to coordinate that communication with Marissa, but we'll want her to be in the room when that training actually happens. So yeah, that is the change to coordinated entry. That does kind of take me into our new user training. You guys can see in the packet, upcoming trainings are going to be next Thursday, October 9th. I can still take people into that training. If we've got anybody, feel free to let me know. We'll have end user group Tuesday, November 11th. That should be our LSA session, so please attend that, or make sure somebody from your agency is in attendance so that we can get those notes. That'll be 2 p.m. November 11th, which is a Tuesday, and then we'll have our November new user training on that Thursday. Thinking about new user, another thing that I want to just float to you guys, going through that coordinated entry training, I am thinking that we want to modify the structure of our new user. This is a place where I really would like some input from you guys. Right now, the way new user works is people basically get a data security and like workflow walkthrough on how to use HMIS. We'd spend like 30 minutes to an hour talking about coordinated entry because that's a HMIS process, and then we just try to get into the system. What I'm noticing about a lot of our new users, and I would look to you guys with guidance on this too, they are pretty fresh in a lot of cases, like new to housing services in general in some cases. And this training feels like they need more than just a basic HMIS walkthrough, and sometimes I think they're actively looking for that, like an intro to the system and an intro to like housing services in general. We don't want to cut those people out. We basically want to broaden this training so that it's more accessible and beneficial for them too. What that would result in for us would probably be just building in Marissa's like 3-hour coordinated entry training onto the one that we currently do. Rather than make it like a full day of training, like of 8 hours, where we do this really intensive HMIS and a really intensive coordinated entry, we're kind of wondering about maybe like a back-to-back. So it would be every second Thursday of the month, and then Friday, 4 hours and 4 hours. But I know that's kind of a strain on your all's time as providers. And I would just wonder if you feel like new users, ought to be coming into that training looking for counsel on like how to interact with the housing system in general, or like how to be a housing service provider, if that's training that you guys are handling internally. And if you think that maybe this is too much, like 2 days is too much, or 2 days would be better because everybody comes out of this training really confused. Like, as we've sent people into this over the past year or so, and I think a lot of our service providers actually have, what has been the reaction? And do we feel like an additional day of training would be helpful or overly intensive for your staff?
I think it would be very helpful to have the extra info, because I know when I've had new staff come on, if they're not familiar with the world, it's us trying to explain how everything goes in the system and works, and then they go to HMIS and it's like, okay, I kind of know what this is, but I don't fully understand how I'm going to use it.
I'm on the same page. I think that our office sort of has a lot to say about like how something like coordinated entry ought to work, and it can be kind of disorienting, I think, even for some of our providers, for how that works exactly or what its targets are. And so it's starting to feel like we need to kind of acknowledge what our place is in that process and just make our training more robust for those newer folks so that they know exactly what our expectations are. And if we have a place to kind of intervene with some system interactions, that's great. Like I said, we want to add diversion to Marissa's coordinated entry training. So I think what we're imagining on that second day would be ultimately something like a diversion workshop, where it's like we're giving a housing triage assessment. Our new users are seeing what that looks like on HMIS, but also seeing what those conversations feel like, and not just like, okay, I'm asking you a bunch of questions, but like, okay, you have been assigned a client for diversion. At what point in this housing triage assessment are you starting to realize this person doesn't need coordinated entry? We need to divert to another resource, because it feels like that's exactly the place where a lot of our new users just kind of become discouraged and are like, oh, man, I thought I had this resource for you. I don't know how to do housing problem solving. I'll talk to you later, or whatever ends up happening. But again, just from an enthusiasm standpoint, like I feel like we lose people at the point of not having a robust enough diversion exposure. So we're hoping, that this helps a lot, even if it comes at the expense of an extra half day for your staff. But we feel okay about that generally as supervisors and stuff. Okay, cool. We're still rolling that out. So I haven't put it on our schedule, obviously, but I would tentatively expect that November training would actually be Thursday, November 13th and Friday, November 14th. And we would host both of those in person, and the second would be kind of more of that workshop diversion vibe. So pretty cool. And I would encourage anybody who, if we go through with that model, and we'll again provide a kind of alert about that scheduling update. If you have folks who have trained recently and they still have questions, they maybe don't need to sit through like a 4-hour security training with me, but they may do really well to come to a diversion and coordinated entry training and like workshop essentially. So know that 2-part component is maybe an additional space for us to engage, like not brand new users, but folks who just like need a refresher, kind of like we're doing with housing triage more broadly with all of our providers. So hopefully a cool tool for you guys to refer back to, for anybody who needs a little extra support from our office.
Question.
Yeah.
Would you all ever look at maybe doing a refresher course for like project specific HMIS stuff instead of coordinated entry? Because I run into that sometimes.
Yeah, I mean, I always would.
Because I was like, oh, it's been so long since I've had to get in and do this. Where do I go? And
Yeah.
like focusing on like the creating household and updates and stuff like that, I think would be helpful as like a refresher.
Yeah, I would definitely love to. I feel like every time we come to DSI, we're always like, here's our training schedule, and also if you want anything individualized, please let me know. But like, that's exactly what I'm talking about. So I am always open to it. It's something that we would like custom schedule, but yeah, at the provider level or project level, like would love to refresh. So
then I'll just get with you separately.
Yeah. And if anybody does have questions about that, please just reach out to me and know that we can schedule, a one-on-one or something for your whole team, whatever you feel like you need. We definitely want to supplement those opportunities to improve data quality. So
the Thursday, Friday evening, so the Friday workshop, you were saying could be open to, like, don't necessarily be the Thursday workshop.
Yeah, I think so. I mean, this is the first time we're having this conversation publicly. This is just feedback that Marissa and I have had, having done a little bit of coordinated entry training. So It's all kind of preliminary, but I would think that, particularly if you guys feel like it would benefit staff, we would want them to be able to come to that. So yeah.
And it would, and these are all Zoom, right?
So now they're in person, and particularly for that workshop, it would definitely be in person. Now for our like agency consults and stuff, I'm always happy to do that stuff on Zoom, but new user is so long and exhausting, we just felt like we were getting better engagement in person. So the Thursday, Friday sessions, both of those would be in person at the Government Center. So yeah. Other thoughts or questions on that? If not, we can jump to just issues not on the agenda or public sharing. Anybody with any notes otherwise?
I guess it's a long shot, but did your HUD email say anything about the NOFO?
So it didn't, but
Okay.
Marissa got an email yesterday, I think I can say this, about the grant inventory worksheet. It's a little more out of my purview, but my understanding is that HUD would have been sending us that to announce what kind of funding we could reasonably expect to apply for if there were to be a NOFO. So getting a document like that indicated to her that our expectation probably ought to be that there will be an application opportunity or a funding opportunity. So obviously there's a shutdown and we won't hear about anything until that's done, presumably. But I think as we got later into the season, we would have expected that not to be the case. But I would just encourage you all, until we hear a solid no, to actually start anticipating that like we'll probably be facilitating something like winter shelter while we're also doing a NOFO. I would start to lean toward that's happening. I know Jeff's language lately has been, we might assume that it isn't, but the grant inventory worksheet for Marissa at least was kind of an indicator that they would release that NOFO. So TBD, but probably. Great question.
Just waiting.
Yeah, I mean, you guys can tell that unfortunately, like, you know, I got an update from HUD yesterday. They sent the grant inventory worksheet, I think yesterday or maybe the day before. Like, all of this stuff unfortunately is coming kind of without warning and really abruptly. So just keep your teams ready, you know, because it'll be a really chaotic time otherwise. If we don't have other questions or public sharing, we can be done. The next meeting is going to be December 3rd, same place at 1:30. We can just adjourn. Do we need a motion?
If we're at the end of our agenda, we can just adjourn.
Okay, well, that's the end, so we can be adjourned. Thank you, guys.